So today we shall be discussing approach to anemia, iron deficiency anemia, oral manifestations of anemia, and a little about megaloblastic anemia. So going to the topic proper, what is the definition of anemia? The disease is characterized by decrease in hemoglobin or volume of RBCs, resulting in decreased oxygen carrying capacity of a red blood cell. Thus, the physiological needs of tissue are unmet. So what do I mean by physiological needs of the tissue? I mean to say the O2 requirement of the tissue is unmet. In females, a hemoglobin of less than 12 gram and in males, a hemoglobin of less than 13 gram per deciliter is considered anemia. So where does RBC production start? RBC production happens in the erythroid marrow, where with the help of iron, folate and B12, RBC is produced. Along with it, hemoglobin is incorporated inside a cytoplasm. Once the red cell mass is released into the plasma, it undergoes red cell destruction. In red cell destruction, there is a hemoglobin released into the plasma. So this hemoglobin and red cell supplies various tissues like kidney, muscle, lung, liver, literally every tissue in the body. But whenever I require oxygen or I require more energy or exercise capacity, the kidney detects low oxygen or high oxygen consumption and leads to the release of erythropoietin, which is a hormone from the kidney. This erythropoietin in turn stimulates the erythroid marrow to produce more and more RBCs. So now that we have seen the definition of anemia, we shall move into how do I classify an anemia. So classification of anemia is based on a famous index known as RPI, a reticulocyte production index. What exactly is a reticulocyte? A reticulocyte is an immature red cell that has lost its nucleus and retains aggregates of RNA within its ribosome. RNA decreases as red cell matures. You can see here the stem cell hematocytoblast is huge and it has a huge nucleus within it. A committed cell is known as a proerythroblast. It goes on to mature and ultimately the nucleus is extruded from the cell. The reticulocyte does not have any DNA in it. It just has a tiny bit of RNA and which ultimately gets extruded out to form the mature RBC known as erythrocyte. Reticulocytes remain in bone marrow for 2 days and 1 day in the peripheral blood. So normally the reticulocyte count is up to 1 to 2%. A reticulocyte count can be used to assess the bone marrow erythropoietic activity. So based on the reticulocyte production index, I can divide my anemia into those which have a low reticulocyte production or a high reticulocyte production. So high reticulocyte production are ones which have blood loss, intravascular hemolysis, metabolic defect, membrane abnormality, hemoglobinopathies like thalassemia, sickle cell anemia, immune destruction like autoimmune hemolytic anemia, fragmentation hemolysis like thrombocytic macroangiopathy. Thrombotic microangiopathy is a fragmentation hemolysis. Next, when the RPI is less than 2.5, how do we further classify? Based on the red cell morphology. So if the red cell is normal sized, if it is normal sized, then we call it normocytic. If the red cell is either decreased in size or increased in size, we call it micro or macrocytic. So normocytic normochromic anemia is basically hypoproliferative. What do I mean by hypoproliferative? That means the number of RBCs that are produced from the marrow has decreased. So the various causes could be marrow damage, iron deficiency anemia, and decrease in stimulation, that is erythropoietin has decreased. Remember what erythropoietin was? It was the hormone that was produced by the kidney in response to hypoxia to stimulate the marrow. So if erythropoietin decreases, the stimulation will decrease. On the other hand, micro or macrocytic is because of maturation disorder. So maturation disorder means it can be cytoplasmic or nuclear maturation. Cytoplasmic defects are iron deficiency, thalassemia, and sideroblastic anemia, while nuclear are folate.